if somebody is known to be hypertensive and you give that person drug, the BP is somewhere high. I don't know if you understand. You give the drug. What the drug does is that it will just go and drag the BP down. As long as the drug is in your system, BP will remain low. So if you go then and check your blood pressure and you realize that it is 120/80, and some other person who has not been taking drug, you have 120/80, you say since your own is now 180/80, but the idea is that it is the drug you took yesterday that brought it down to that level. If you don't take drug for 2 or 3 times, it will go up. Once the drug leaves your system, the BP goes up again. You understand what I'm saying? So in that case, even when the blood pressure remains like 110, you still have to give anti-hypertensive because it is the drug you took before that is bringing it down. Why do we need to continue taking anti-hypertensive? Because we are managing BP. We are not treating it. It's different from ulcer. The general notice somebody have, he tell you, I have ulcer. Ulcer is just a wound that have reached the muscular mucosa. It is a treatable condition. Simply means that by the time you treat it, it will go. And you don't need to keep on reminding yourself that you have ulcer. And normally there is something that contains pepper. It doesn't give ulcer. Now somebody took a pineapple, doesn't give ulcer. You take vitamin C, it doesn't give ulcer. But when people say I have ulcer, now they say the different thing. Somebody might have a dyspepsia, no problem. But ulcer is not a disease that you manage. Ulcer is a disease that you treat. But the problem with Indishoji is that some of them will go and treat the condition that should be managed and try managing the condition that should be treated. So if there is ulcer and you do, even if there is H. pylori and we have found out that it has ulcer, there is H. pylori eradication, you eradicate it. Take omeprazole or rabiprazole, any other drug you might take at the stipulated time, it is expected that the ulcer has gone. So you don't need to start labeling yourself again, then we're ulcer, even when the pain is not related to ulcer. So by the time you are coming to the hospital and you come, somebody have high blood pressure, somebody have failure, there is fluid overload. You give some drugs, the fluid now dry. It is the drug that dries the fluid. By the time you feel that the fluid has dried, it is the time you come back to the hospital. Maybe if you are on the drug of 100 milligram, we can now bring it down to 50, 40 or so, and tell you the dose that we will now continue on. But somebody will now go home. He will now go home, only to come back when the complications of the ailment has come back. It doesn't work that way. So if you are coming to the hospital and after test, after diagnosis, endeavor to ask the doctor, this thing, the treatment you are giving to me, is it going to cure the disease? In fact, there are some conditions that cannot even be treated and cannot even be managed. All we do is that we try to prolong the life of the person. But the one that your life is not at stake can be either be managed or treated. And the way you treat this condition is different from the way you treat this condition. Again, the drug that you are given for a particular condition depends on the expected outcome, and it all depends on the age of the person. Let me explain. If somebody comes with pain and that pain is so severe, we can look around and say, if we give this drug can cause kidney problem in the future. Now, the next question is, how long is this drug likely to stay before it can cause the kidney problem? Now, if this drug is going to take up to 2 years or 3 years before causing the kidney problem, if you look at the person's condition, assuming that this person have a cancer of the colon or something, and you are sure by statistics that this cancer can kill this person before 3 years, I don't know if you understand, you can say, let us give him the drug. Before the side effect of the drug will come, some other thing might have killed the person. Now we can give that person that particular drug individualized. Now another woman, both the wife, who might be suffering from joint pain or small pain that is not even threatening her life, will say, my husband used to take this drug and don't have pain and don't have pain. She will go and take. Now, we gave it to your husband because we know, quite all right, there is possibility of side effect arising from this drug. But before this side effect will arise, some other thing might have killed this man. So let's not allow him to suffer. There's nothing we can do. There are some drugs like diclofenac, which we know can cause kidney injury. It can cause kidney failure, diclofenac. But assuming that you see a patient whose kidney has already died, you understand what I'm saying? And eventually, this person is going through severe pain. You can still write diclofenac. Not because you don't know that it can cause kidney injury, but this person we are dealing with already have end-stage renal disease. Nothing can be done to that thing again. Another person whose kidney is good, we go and say, oh, Dr. Derogwa, Dr. Derionya Mbone weapon. Now, that particular drug that is good for one sibling, Ejimanab, based on their medical condition, the same drug that cured this person might become a poison to the other person. So somehow, drugs is actually individualized.